So in this talk, we're going to discuss the role of Optune in brain tumor treatment. Optune utilizes tumor treating fields, which is a first-in-class approach that capitalizes on the inherent physical properties of a dividing cell and physics in order to kill cancer cells. I have been on the advisory board for Novocure for Optune before it became Optune, as well as an expert user group for Novital mapping that resulted in a publication for guidelines. Otherwise, the other things here are not part of conflict of interest. We're going to talk about some background about brain tumors in general, mechanism of action of tumor treating fields, some clinical trial data, review the Optune device a little bit, as well as just some of the logistics of Optune therapy. So for background, so brain tumors overall account for about 1% to 2% of all cancers, so they're fairly rare. And if we concentrate just on the red box here, which is the malignant brain tumors, glioblastomas constitute about 50% of all malignant brain tumors across all ages, with a peak incidence around 55 to 60 years of age. These tumors are cause about 2.5% of cancer deaths, and are the third cause of cancer deaths in patients from 15 to 34 years of age. So they have a disproportionate amount of mortality and morbidity given their incidence. And this is predominantly due to just increased mortality, morbidity. A lot of patients end up with functionally limiting neurological deficits by the time they end their course. And it's also compounded by the fact that these patients require multimodal treatment with neurosurgery, radiation therapy, as well as chemotherapy. When we look at brain tumor survival rates over the past 30 years, for brain tumors, they haven't really increased much. About 1% increase in survival compared to about 20% with all cancers overall. So despite increases in surgical techniques, advances in radiation therapy, new chemotherapy drugs, we're doing about the same. Oh my, this slide somehow messed up. Well, very interesting. I have no idea why this is doing that. So basically, this is a little bit of a timeline for treatments for glioblastoma, including kind of standard therapies that are FDA approved. So long-standing since the dawn of neurosurgery resection has been the basically the gold standard for treating brain tumors. In the mid-70s to early 80s, it was established that radiation therapy provided survival benefit. Then in the early 1990s, BCNU or carmustine was shown to provide survival benefit. Then we had the development of Gliadel wafers, which is a carmustine-based wafer that you guys should be very familiar with in the neurosurgical world. That was approved for recurrent glioblastomas in 1996. Temozolomide or Temodar, our chemotherapy agent, was approved for recurrent malignant gliomas in 1999. Then Gliadel wafers were approved for upfront treatment in 2003 with the STOOP protocol. In 2005, temozolomide upfront concurrent with radiation therapy and adjuvantly became gold standard for treatment of glioblastomas. Bevacizumab was on board in 2009 for recurrent glioblastomas. 2011, tumor treatment pills came on board for recurrent glioblastomas. And in 2015, tumor treatment pills came on board for upfront management. So over the past 30 years, we've basically had 4 FDA-approved treatment modalities for glioblastomas come on board. So what has all of this done in terms of impact of therapies? Well, without any treatment, the average survival of a glioblastoma patient is less than 3 months. With maximal surgical resection and radiation, that increases to about a year. If you add temozolomide to that, it's between 14 and 17 months. And with tumor treating fields added to that, it's along the lines of about 20.5 months. So in the neuro-oncology world, we talk about quadruple therapy, or new treatment paradigm. That gold standard includes maximal surgical resection, radiation with concomitant temozolomide, followed by temozolomide in tumor treating fields. So when we talk about the mechanism of action of tumor treating fields, these are delivered by a system called Optune. And these single-use transducer arrays are applied directly to the scalp. So individuals have to shave their head. These arrays get put directly to the scalp. This shows just 2 sets of arrays. There's actually 4, but it would muddle up the picture a bit. And tumor treating fields are provided directly to the tumor bed. The arrays deliver tumor treating fields at a low intensity and intermediate frequency. And to kind of understand exactly what tumor treating fields are, we have to address some common misperceptions. So tumor treating fields are not an electrical surge that's going through tissue. Tumor treating fields are not a form of radiation like X-rays or protons that bombard tissue and cause DNA damage. And tumor treating fields are not magnetism. So exactly what are tumor treating fields? Alternating electrical fields. It's kind of a little bit of an abstract concept. So one way to kind of consider it is gravity. Right now, all of us are being impacted by the Earth's gravity. That's why I can have 2 feet on the ground. That's why you guys can remain seating in your chairs. Astronauts in space do not have the effects of the Earth's gravitational pull. So when you see them on the space shuttle, they are literally just moving around in 3 dimensions in space because they have no gravity to pull them in one direction. As they come down for landing, the gravitational pull starts to pull them down, and once they arrive on ground level, then the gravitational field is aligned with them and they're able to walk. Alternating electrical fields, basically instead of acting on mass like gravity does, alternating electrical fields work on charged particles. So they work in the same way as this concept of gravity, is they only impact charged particles, which then will align them in their gravitational field. It just so happens that when a cell divides, charged particles are part of that process. So alternating electrical fields can put a kink into the cell division process and be used as an anti-tumor therapy. And we're going to work through this just a little bit. So this is normal cell division. So in a cell that's normally dividing, you have the nucleus with the chromosomes inside of it, and then you have proteins that are floating around in 3 dimensions in the cytoplasm of the cell. And we're going to talk about 2 proteins in particular, tubulin and septin. And these are very highly charged proteins. They're one of the most highly charged proteins in the body. And it's that highly charged part that allows them to help cell division. So when cell division first starts, the nucleus dissolves, the chromosomes line up in the middle. And then tubulin and septin undergo this 3-dimensional change where they start linking up. And literally kind of like Legos, just start clicking in to form mitotic tubules. And those form the mitotic spindles that actually then will attach to the chromatomes and help them split. And the septin helps form basically this contractile apparatus, which helps basically the entire cell separate into 2 pieces and have 2 daughter cells. If you use this same model and you put tumor treating fields on board, what you'll find is those highly charged tubulin and septin molecules will then align with the field. And the field's going to be alternating, so it's going to be here, it's going to be here, going to be here, going to be here. And it's not going to be able to link up and form those microtubules. It's not going to be able to link up and form that contractile apparatus. So what happens is the entire mitotic process is slowed. It often doesn't complete itself, and the cell's just basically left to disintegrate in mitotic death, because a dividing cell is a little bit like a pregnant woman. You can only be pregnant so long, right? If the baby's not born, both mom and baby will die. Once the cell starts to that dividing process, its nucleus isn't active, so the brain of the cell's not doing its cellular processes to keep it alive. The cell will die. So here are just some pictures of real cells to kind of make it a little bit more concrete. And in these cells, they have a green fluorescence that have been linked to tubulin, and then fluorescent photography is used. So here, oops, what did I just do? So here you have a normal cell. Here you have the cell that's rounding up, getting ready to divide. And I don't know if you can see it here, but you can see the mitotic spindles being formed here. And then you have cytokinesis, you have the cell splitting into two daughter cells. Then I want you to notice they've put a time frame on this. So if you notice, this entire process of going from one cell to two cell takes about an hour. And now if we apply tumor treating fields, you see that the cell rounds up for cell division. You never get a spindle formation. You never get that cleft for cell division. And then you get all of these little irregularities on the surface. And that's called blebbing. And what that is that septin protein. With tumor treating fields, it's all over the place. And it forms the contractile apparatus. Well, if it is in complete disarray, it's going to cause certain parts of the cell membrane to contract, and you get these little blebs. So this, and then if you look at the time course of this, you see that this is almost 6 hours, and the cell still has not undergone its normal division. It's just still sitting there as this amorphous blob. So kind of the combination of no spindle apparatus, blebbing, the increased time, all is what we call basically mitotic catastrophe, and this cell will eventually die. This is just another presentation of it with a couple of other dyes to show. The one on the left, A, is normal cell division. The one on the left, B, is with tumor treating fields. And then these down here basically show you progression of the development of those blebbing or those septum dislocated contractions there. So while tumor treating fields can prevent cells from effectively forming the mitotic spindles and dividing into two daughter cells, some cells escape. They still divide into two cells, but they often don't do so appropriately. So here is a cell, and this is the same picture. I've just put circles on one side because it was a little hard to tell. So this is a cell that's divided successfully with tumor treating fields, but what we have is one cell with two nucleus and one cell with no nucleus. So this cell is going to die because it doesn't have what it needs to maintain life. This cell with two nucleuses is going to have a very hard time surviving, and if it chooses to divide, it's likely going to die in the process of cell division. And this is kind of putting it kind of in the same way. Here we have basically normal control, so you have your 46 chromosomes and 23 pairs, all divided nice and normal. Down here is what we can see with cells after tumor treating field exposure if you do chromosomal analysis. So you'll see that some of these chromosomes don't have a pair, and over here you have chromosomes that have extra copies. So these cells are still living for the moment, but they're not going to thrive, and if they try to divide, that cell division is likely not going to be successful. So how does this all work in real life? So here we see basically they've plated out glioblastoma cells in the lab, and they've done this in triplicate. The top row is control, so they basically plated these cells out and let them grow. The bottom row, they plated the cells out and then exposed these petri dishes to tumor treating fields. And what you see is, you have a lot more growth. You have a lot more cells, colonies up here. Down here, you don't have as many. So tumor treating fields will reduce the clonogenic potential or the growth potential of the tumor. So kind of a summary of tumor treating effects. It disrupts the normal mitotic spindle assembly, leading to mitotic catastrophe or cell death. It can cause abnormal chromosome segregation and chromosomal alterations, and those cells are going to be less likely to thrive and survive and less likely to successfully divide further. Basically, it creates all the cellular debris and it has to be cleaned up, which is the induced autophagy. And then we have no effects on non-dividing cells, just like we don't feel the effects of gravity. It's just the way it is. We're under a gravitational force. If we try to jump up, we can feel the force of gravity because we will come down. But a normal cell can have these alternating electrical fields, but because they're not using those charged proteins at the time, they're unaffected. And if we go on to some clinical data, and one of the things I want to mention before we talk about the clinical trials that have been done for this is tumor treating fields, the Optune is a device. And it's a common misconception that FDA approval for a device goes through a different process, which is true. A lot of FDA approval for devices, you just have to demonstrate safety. You don't have to demonstrate efficacy or benefit. But what Novocure did with all of their clinical trials is they approached it as if tumor treating fields was a chemotherapy agent. And all of their clinical trials were done to the same standards of if this was a chemotherapy drug. So these clinical trials are meant to demonstrate efficacy as well as safety, even though the treatment ultimately is a device. So the first randomized trial that was done looking at tumor treating fields for glioblastoma was the E11 trial, and this looked at recurrent glioblastoma. So these patients had already had treatment with maximal surgical resection, radiation, chemotherapy, and they did not designate that it had to be at first recurrence. It just had to be, they didn't have chemotherapy, they didn't have radiation or surgical options at that time. Patients were randomized to either tumor treating fields by itself or to physician's best choice chemotherapy. And what they found in this trial is that best choice chemotherapy should increase life expectancy. It should probably double life expectancy over doing nothing by itself. And when they look at this, tumor treating fields did as well as physician's best choice chemotherapy. So it was non-inferior. But one of the things that they did note is they did some quality of life analysis with this study. And patients on the Optune, or the tumor treating fields arm, reported better quality of life. And so when they looked at these scales, they had better quality of life. They had improved cognitive functioning as well as improved emotional functioning. And part of the FDA approval of this for recurrent glioblastomas did use quality of life as part of their approval. And this is actually the first cancer therapy where FDA approval has been in part contingent upon improved quality of life. So after the tumor treating fields was approved for recurrent glioblastoma, Novocure said, well, what happens to it out into the community? So they developed a patient registry data set called PRIDE, and at the time, about roughly 90 centers in the United States were certified to provide Optune therapy to their patients. And over the course of 2 years, approximately 460 individuals received tumor treating fields for recurrence. And they went back and retrospectively reviewed that data set and compared it to the EF11 trial data set. And so what this slide here shows, you have basically your patient registry data, and then you have your two arms of the EF11 trial. And what this shows is demographically, as far as age, sex, and recurrence, things were pretty even, or KPS rather. For recurrence, what they found is that in the community setting, more folks got this at first recurrence than in the clinical trial. So people started therapy earlier in their disease course. And when they looked at prior therapies, about 50% of people in the registry set had prior bevacizumab, as opposed to about 20% in the clinical trial. So when they did this retrospective review, and retrospective reviews compared to a phase 3 clinical trial are often a little bit tricky, but what they found is that progression-free survival and overall survival were improved in the registry data set. So here we have survival curves, and here you have the registry set, and here you have the clinical trial that are basically the same. When they looked at long-term, so 1-year survival and 2-year survival, they also found that folks did much better with tumor treating fields in the community setting than on the clinical trial. One of the potential explanations for this is the fact that more people on the data registry set started at first recurrence. And this graph here shows survival curves at first recurrence, second recurrence, and third recurrence. So certainly starting this therapy early does seem to impact overall survival in this disease. So after that, they looked at tumor treating fields up front. And so the EF14 trial was designed to enroll patients after they had maximal surgical resection, radiation concurrent with temozolomide. Then patients were randomized to either temozolomide and tumor treatment fields, or just tumor treatment, or just temozolomide alone. And so what happened with this trial is, as with all clinical trials, there's preset interim data analysis. When they did the interim data analysis for this trial, they found that there was a benefit in both overall survival as well as progression-free survival in patients that got tumor treating fields along with their temozolomide. So an independent data management analysis suggested that they stop enrollment to the EF14 trial. The FDA then approved this for upfront use. The company continued to follow the patients that were enrolled in this trial. These patients were allowed to continue with tumor treating field treatments if they had a recurrence. And so then we have several data that came out of it. I'm getting a time card, so I'm going to go quickly. So basically, when you look long-term, concentrate on these numbers here. So 5-year survival on that clinical trial, you had a 5% survival rate with temozolomide and a 13% survival rate at 5 years with patients that got tumor treating fields. The longer you use the device, so if you wore the device for 90% of the time, you did better than if you wore the device for 50% of the time. And this looked at folks that were really compliant. So if they had the arrays on, connected to the alternating electrical fields little computer, powered on for greater than 90% of the time compared to tumor treatment fields, they did significantly better with overall survival and progression-free survival. Quality of life, the only thing that the tumor treatment fields had a worse quality of life from was people said that they had a little itching and irritation underneath the scalp arrays. Otherwise, quality of life standards were either improved with tumor treatment fields or the same as temozolomide alone. And when they looked back at a planned analysis of what happens after you fail, so when people continue tumor treating fields and get a second therapy, what they found is folks continue to do better. And what they found was that many patients, both on the tumor treating fields arm as well as just the temozolomide arm, got bevacizumab at recurrence. And this slide here shows that tumor treating fields plus bevacizumab did better than bevacizumab alone in that analysis. It's retrospective, but it is significant. I'm going to skip these. So based upon all of these data, the NCCN guidelines give this a Category 1 recommendation for newly diagnosed GBMs, kind of solidifying the quadruple therapy approach. When we look at radiographic responses, we have a lot to learn. So in this slide, you have somebody treated with tumor treating fields. The post-contrast images are on top. So here you have at baseline. Here you have 4 months later. And you may say, well, that's bigger. T2 still really a lot. But without changing any therapy, 28 months later, you see a major radiographic response and improvement in the flare. So it takes a bit of time. But with all things, to every rule, there's an exception. This is a patient where you were treated with tumor treating fields for a glioblastoma, and this is baseline, and this is the amount of enhancement after 1 month of tumor treating fields. And you can get pseudoprogression or treatment response with this as well, so you have to kind of factor that in following imaging. They are looking at this for brain metastasis. They also are looking at tumor treating fields for other tumor. It's been FDA approved for mesothelioma. They have patient data for lung, ovarian cancer, pancreatic cancer, and lab data for a lot of other cancers. I put this slide up here. If you notice down here that the frequencies are very different. So what they found in their preclinical models is that the optimal frequency for these alternating electrical fields depends upon the size of the tumor cell. So you cannot take the Optune device that's approved for glioblastoma and use that same device to treat somebody with breast cancer metastasis to the brain or lung cancer metastasis to the brain, because the frequency that's going to be optimal for those other tumors is different. So the Optune device, I put this up here to show you that this woman is wearing the Optune device, so you can camouflage it quite well. You wouldn't know that this was a medical picture here. There's a lot of misnomers for the Optune device. Everybody calls it a cap. It's not a cap. They call it the electro cap, the magna cap. There's all kind of things that drives us a little crazy, but it is what it is. These are the transducer arrays. Historically, they've been white. They just recently introduced flesh color arrays that this woman is wearing here. This is the prescription or the treatment map for what it looks like. So you have this basically this androgynous picture, and you have a layout of the arrays that are placed to maximally concentrate the alternating electrical fields to the tumor bed. And so you basically take all these pictures and say, okay, you know, here's the ear, arrays go here. This is just the arrays, and then here is the electric field generator. If you go to the exhibits, they have an example of it. It looks like a large pair of binoculars. The battery is a cylinder. It weighs about 2.7 pounds. Comes in a bag that you can configure to carry in multiple ways. This is just placing the transducer arrays, which is basically a little bit like placing Band-Aids on. Here is the entire setup. This is a Generation 2 setup. The Generation 1 setup, which was much larger and cumbersome, weighed about 7 pounds, was bigger. And so you can imagine if you have a 100-pound kind of frail brain tumor patient that's going to be carrying around a 7-pound bag, how easily that might throw them off if they have a little bit of a hemiparesis or something, whereas a 2.7-pound bag is going to be a lot safer. Currently now it is a direct-to-patient distribution model, so the physician writes the prescription. The Novital mapping, which tells you where to put the arrays to concentrate the electrical fields at the tumor bed, can be done by a physician that has been trained in Novital mapping or by the Novacure company. They have a device specialist that brings all of that gear to the patient's house, helps the patient look at the map, shows them how to put the arrays on. The company has 24-hour support so that if there's alarms going off, the patient can call and figure out what's going on. The company does bill third parties, which has been very helpful, because if there's so many variations of insurance, and as your patient's the first one the insurance comes around, they don't know what this is, they don't know how to build the device. So it gets very cumbersome. And then the patient comes back and sees the prescribing physician, who looks at their compliance, looks for any kind of toxicities from the therapy. Medicare historically has been a holdout as far as covering this. As of September 1st of this year, Medicare will cover it. Along with everything that's covered by Medicare, there are bells and whistles that you have to adhere to. So your notes have to have certain information like Karnofsky Performance Scale scores and other things before Medicare will approve it. But it's just a matter of learning what they want and doing it. So the approved indications are age greater than 22, because that was the youngest patient in the clinical trials, glioblastoma histology, supratentorial tumors only, because it's hard to get proper field treatment in the brainstem and skull base, newly diagnosed glioblastoma, as well as recurrent glioblastoma in monotherapy. Contraindications are important to be aware of. If you have an active implanted medical device, such as a programmable shunt, stimulator of the spinal cord, pacemaker, defibrillators, safety has not been established for that, so it's a contraindication. If you have a skull defect, it's a contraindication. Bullet fragments, known sensitivity to conductive hydrogels, because that's what keeps the arrays on the skull, and pregnancy. When we look at side effects related to the device, the main thing is skin reactions. And usually it's a contact dermatitis that's associated with this. The thing that we have to be really concerned about is occasionally it can cause skin ulcers. So you want to make certain that the arrays and that hydrogel is not going to be on top of your craniotomy scars or any of your craniotomy screws, because if you get an ulcer in those locations, you can end up with wound infection, dehiscence, and all kind of ugliness. In order to combat this, they have a specific protocol where you basically shift the arrays, every arrays change. So basically your skin gets a little bit of break from that hydrogel adhesive. The hydrogel adhesive is like the adhesive that they use for EKGs. And if somebody has an EKG on for a few days, they take it off, the skin's red. It's the same stuff that holds on the arrays. Here is just some examples of how to camouflage the arrays. You can pretty much do anything with the Optune except get it wet, because it is a computer and electrical setup. In Colorado here, we have a lot of people that go hiking, running, biking with the device. For showering, you basically just wrap all the electrical cords in the arrays, stick it under a shower cap, shower, and then undo the process at the end of that. These are just examples of people using Optune on battery power. These are people, so if you are just sitting around the house, sleeping, working at a desk, you would plug in the device to an outlet. The treatment goal is 18 hours per day or 75% of the time, and certainly it's been very well established that the more they use it, the more efficacious it is. But they use a protocol that kind of allows people to bank hours. So if you have a wedding you want to go to, or you're running in a road race and you really don't want to mess with the Optune device, you can basically plan ahead and wear it more than 18 hours. So then you can have a day or two off of it for your activity, start back up, and over the course of a month you still maintain the appropriate level of treatment. Here's an example of a compliance report that you'll get. This is one of my patients. I put the site patient as 1111 because of just patient confidentiality. You can see that this patient has about a 93% compliance. What I found in patients, and generally we have really no problem in getting above 80% compliance unless people have a lot of skin reactions that they have to take breaks for. So in summary, this is a first-in-class treatment using alternating electrical fields, or TT fields, to capitalize on a mechanical property of a dividing cell. Clinical trials consistently show increased overall survival as well as progression-free survival, as well as improved quality of life with use of the device. And generally the device is well tolerated without overlapping side effects with chemotherapy, with mainly contact skin reactions as the primary side effect. And that is all I had today.